As a women's health fellow at the moment with the Training Hub. And this is the first of a new series of 3 women's health webinars that we've got running over the next few months. So it's great to have you here joining us today. I'm really pleased to be joined by Harriet, another GP with a special interest in women's health, and again, a menopause specialist. And Harriet will be picking up your questions, so do post them in the chat and we'll come to them regularly through the presentation. So if there's anything you want a bit more clarity on, got any questions as we go, please pop them in the chat. So today we're talking about PMS and PMDD. It's quite a hot topic. It's common. It's quite easy to miss if we don't think about hormones. And it's probably something that many of us haven't had that much training in before. So it seemed like a good topic for us to talk about today. There are recognised treatment pathways. There are really positive things that we can do within primary care to make a huge impact for women that we're seeing with PMS and PMDD. We're going to try and make this session really practical, look at what we can do in primary care, look at the guidelines, share lots of useful resources with you as we go. And as Kira said, all those will be sent on to you after the presentation. And although I'll be referring to women today, I want to acknowledge that not all women were assigned female at birth and that some trans men and non-binary people may also experience PMS and PMDD. But to get you started thinking about what you know already, I'm just going to briefly outline 2 recent primary care cases that Harriet, 2 women Harriet's been working with. And then we're going to come back to these at the end of the presentation to see if we can apply what we've been talking through. So this is our first case, a 43-year-old having regular periods with a really long history of cyclical mood changes. She previously tried SSRIs, which had helped a little bit, but a year ago, going on combined hormonal contraception made a really, really positive difference. She said that she felt well for the first time in years and years. And although she didn't have any contraindications to combined hormonal contraception, unfortunately at 6 months, she was admitted with chest pain and was diagnosed with a PE and was really despondent about all of her symptoms recurring, having had to stop her combined hormonal contraception. She's having a couple of hot flushes, but no other classical symptoms of perimenopause. So just to encourage you to think, what might your approach be? What might you talk through? What might you offer? And as I say, we'll come back to kind of sharing some thoughts and looking at our management plan a little bit later on. Second case is a 44-year-old woman who wondered if she was in perimenopause. And she has a background of long-standing generalized anxiety. She shared that she'd felt quite dismissed and unsupported by healthcare professionals over the years. She'd had investigations with neurology some years ago now, and more recently for possible epilepsy. And she herself had identified that her symptoms of both anxiety and dissociative symptoms were only happening in the luteal phase of her cycle. She tried to talk to her neurologist about this, who she felt didn't really understand or listen to what she was saying and advised her to go on some medication. So again, just pause for a moment, think, well, what would you be thinking of in that sort of situation? What would you be wondering about? What would you be thinking to offer? So I'm going to begin by starting with some definitions. What do we mean by PMS? What do we mean by PMDD? There are a few different definitions. If you have a look and do some research, they overlap, but they do vary a little bit. But essentially, PMS is a spectrum of distressing symptoms, physical symptoms, behavioural symptoms, and psychological symptoms that haven't got another organic or psychological reason and that regularly recur in the luteal phase of each menstrual cycle and then resolve or really significantly improve by the end of a period. And then PMDD is a severe form of PMS. defined in DSM-5 as occurring when there are at least 5 out of 11 distinct symptoms. I'll show you these on the slide a little bit later, and one of those must include mood. And the symptoms experienced are severe enough to affect daily functioning, so affecting school, work, or relationships, so really impacting on daily life. And there are different types of PMS and PMDD. Just to kind of outline these really, because I think it's helpful for us in terms of understanding and looking at the management. So our core PMD is essentially just classic PMS. And then there's a classification around variant PMDs, which are different types essentially. So you can have a premenstrual exacerbation of an underlying disorder like depression, like epilepsy, like migraine, something that will recurrently be worse in that luteal phase of a cycle. You can have a progestogen-induced PMD. So that's where somebody may have symptoms that are coming from progestogen that we're perhaps giving through contraception or HRT that can give these PMS type of symptoms. And you can have a PMD without somebody having a period. So if somebody's using the IUS, for example, and is amenorrheic, they may still be experiencing cyclical symptoms, but it can sometimes be much trickier for them to recognize that without the period being there. It's a lot harder to notice. And then there are non-ovulatory PMDs, which are quite uncommon, not much research and understanding about them, but thought to be due to ovarian activity in the follicular phase, not relating to ovulation itself. This is quite a busy slide, but essentially it illustrates these different types of presentations, which, as I say, can be helpful in terms of just that real clarity of thinking, right, what is it that's happening here? And of course, the more we can be confident as to what's happening, the better we can think about some management strategies. So this is from the RCOG Green Top guideline around management of PMS and PMDD. So you can have a look at this slide and see that these little graphs are really showing the impact on quality of life and the timing through the cycle. So they can help us to look at that cyclical pattern of symptoms and the impact of symptoms, and then use different factors in terms of helping us kind of really just try and think, right, what is it I'm dealing with here? And there are many, many symptoms, and one strong theme when you look at reports from women about their experience is that they've often received multiple diagnoses along the way, particularly with PMDD, that symptoms can often be put down to other things because there can be a huge overlap with other conditions. This is the differential diagnosis given in the CKS guideline. Talks about depression, anxiety, hypothyroidism, anemia, dysmenorrhea, endometriosis, big long list there of different conditions. And I think I'd add to that list bipolar and ADHD, two other conditions that quite commonly seem to sometimes be misdiagnosed, where the diagnosis might be PMDD. And of course, there can also be premenstrual exacerbations of some of these conditions, so it can be really difficult. But again, I think that clarity for us in thinking hormones, where we've got a collection of different symptoms, can be really useful. In terms of the etiology, well, of course, we don't see PMS before puberty, during pregnancy, or after menopause. So we know there's this relationship with cyclical ovarian activity, but the precise etiology is still unknown. There is an impact, it seems, on GABA and on serotonin, and it seems to be that some people are really sensitive to the fluctuation in hormone levels. And that's perhaps why those with PMS may also experience postnatal depression and mood changes at perimenopause too. This triad of hormone-linked mood conditions. There is some recent work that's shown a genetic variation, so a risk for PMDD being associated with a variation in the ESR1 gene, an estrogen receptor gene. So there is more understanding coming in terms of the etiology, which again, I think can be helpful for people with a lived experience to know that, that there are potentially genetic factors that have led to this happening. And this is common. So in terms of prevalence, it does depend on which definition is used, but the reported prevalence of moderate to severe PMS is up to 30%. And probably that's underreported in certain communities. And for severe PMS and PMDD, 5 to 8%. And then I just put some comparative prevalence rates here on the slide, again, just to really prompt some thought and reflection. I expect many of us are looking for hypothyroidism, perhaps more often than we're considering PMDD in terms of our differential diagnosis. Many of us will have many more people coded on our practice registers with hypothyroidism than with PMDD. So there's potentially a little bit of work for us in terms of supporting people in reaching that diagnosis to then be able to look at appropriate management. Harriet, anything you want to expand on or anything in the chat so far? Oh, you're on mute.
Sorry, no one's put anything in the chat as yet. So do everyone feel free to put things in the chat as we go along if you've got questions, and then we can try and answer them. We've got a couple of more question times, I think, haven't we, Sam? But yeah, I think I would definitely highlight the delay in diagnosis of PMS and PMDD that can be really have a massive impact for women, and I've seen it many times in my career where women have come in and described these symptoms that they often will come in and have identified as cyclical, but they haven't felt listened to, or felt that they've got the answers that they needed, and there are opportunities for really effective treatment. So I think just having an awareness, and as Sam highlighted, the numbers and the suggest that we are underdiagnosing this condition.
Thanks, Harriet. Yeah, absolutely. So in terms of thinking about making a diagnosis, so as we've said already, there are many, many different symptoms, more than 150 that have been recorded. And we can group them into different kind of categories, if that's helpful for how your mind works. So we've got kind of psychological symptoms like low mood, anxiety, mood swings, irritability, kind of feeling out of control, poor concentration. There are physical symptoms, things like breast tenderness, headaches, bloating, acne, and a GI disturbance. And then behavioural symptoms, perhaps less commonly known about, things like a change in a visuospatial ability, cognitive ability, feeling more clumsy, having more accidents. So a real kind of range of different things that might be noted. And in terms of PMDD, I mentioned earlier that there were 11 symptoms, and to reach a diagnosis, we need to be looking at least 5 of these 11 symptoms, including one of the ones shown in blue here on the slide, the core emotional symptoms as they're known. So this can help us in terms of that clarification between PMS and potentially PMDD. So how can we actually put that into practice? How can we kind of think? We can't ask about 150 different symptoms in our consultations, but there's lots of tools out there now that can really support us to work with women to kind of help raise this and think about it. And looking at something like a symptom diary using a tracker over a couple of cycles can be really, really useful, both to show the different symptoms that somebody's experiencing and also to show where they occur in the cycle and whether they then go again as that period is coming to an end. So this is really the key to the diagnosis, is thinking hormones and then looking for that collection of symptoms at that particular time of the cycle. And really thinking around whether those symptoms are impacting on quality of life. So there's a number of resources here that women can use that can support that. Symptom trackers, symptom diaries, kind of apps that people can use that can help people to record. And it can be really helpful for that clarity. Of course, symptom tracking doesn't suit everybody. Some people can, if they're getting a lot of anxiety around their health, their physical health and their mental health, it can be tricky because it's encouraging them to focus on all of the things that aren't going so well. But also then if they can see that actually things are resolving and there's a better period of time for a few weeks at the start of the next cycle, that can be super useful in terms of understanding what's going on. So we'll share these resources with you later. But yes, very, very helpful. In secondary care, the gynecologists sometimes use GnRH agonists to confirm or establish a definite diagnosis by essentially inhibiting the cycle. They'll often use them for around 3 months, and you would expect symptoms to resolve. Blood tests aren't helpful for us in terms of making a positive diagnosis of PMS or PMDD, but of course you might want to be doing them for other reasons in terms of thinking about that other differential. But they're not going to help us. Looking at hormone levels per se or anything is not going to help us to make that diagnosis. Anything from the chat, Harriet?
Attention. No, nothing in the chat again. I think symptom trackers are useful and women will often come in having used them for a period of time. So I know that, in the diagnostic criteria, we're not meant to make the diagnosis until we've got at least sort of 2 months of symptom tracking, but that's often unnecessary to send women away to do that because they've often done it themselves. I was just about to write that young women seem to like the Flow period app and cycle tracker. Seems really popular. One person uses it and then everyone else does, and that's also got a symptom tracker on it as well. So I've seen women use that one, especially younger ones too.
Yeah, thank you. Yeah, there's much more awareness, I think, isn't there, particularly in younger women now. So I agree. A lot of people have thought about this themselves. Yeah. So yes, there is often some tracking that's already been done, which is super useful.
I mean, I think certainly for the more traditional symptoms, women have thought about this themselves. But sometimes that's the easier spot, isn't it? It's the women who are getting some of the symptoms that we're less familiar with and women are less familiar with, that it can be more of a challenge to pick it up with.
Yeah, absolutely. And then I wanted just to touch a little bit about the impact, particularly of PMDD, just to really kind of illustrate about why it's so important for us to be thinking about this as a diagnosis and making a diagnosis so that we can support people. So remembering this is really common, 5 to 8% of women. And this is a graph from a paper that was published looking at people, as you can see, with PMDD and a comorbidity, or PMDD alone, and how many will have suicidal thoughts, suicide attempts. It's really, really significant. So 2/3 of those with PMDD alone having active suicidal ideation. So this is a really significant kind of risk factor in terms of deaths by suicide that we can be looking for and supporting people with, something that we can be treating effectively as long as we've recognised it. And there can be incredible outcomes, incredibly negative outcomes for people when they're experiencing PMDD in terms of their own health, their well-being, but also for the people around them too, in terms of partners, children, people's ability to be working. So really quite profound impacts. I've posted a link here to a clip from BBC News. It's a short kind of YouTube clip of lots of quotes from women, of people with lived experience, which is really powerful. So if you can spare a couple of minutes at a later date, I'd really encourage you to have a little listen. It's really useful. And I've pulled out just a couple of quotes from a different paper, again, just kind of illustrating some of these ideas. All of a sudden, it went pitch black. My emotional mood changed drastically, and I could never see any outside things. Like things had happened that made me upset or made me dark. So, as a very young woman, I was wondering why I felt that darkness. I felt like there was no point in living. I just felt like everybody thought I was making it up. And there's nothing worse, is there, than when you feel that everyone thinks you're lying. When I'm on chemical menopause, I'm fine. Like it's amazing. Yeah, like I've been able to keep a job, I'm in a relationship, I'm able to actually think about my future. The only time I've been stable was when I was pregnant and breastfeeding. My mood was stable. I was stable. I didn't get nothing because you don't get no periods. And even my husband would say the most stable he has known me was when I was pregnant. Other than that, he has just felt like he has lived with a whirlwind. So I think, if we kind of put ourselves in somebody else's shoes, and of course, some of us may have our own experiences, being that this is so common, but it's really, really significant. Yeah.
And I think there still is, the leftover sort of, it's just your hormones sort of attitude from people who are less aware of it, sometimes from partners in relationships and things. I was talking to a woman yesterday who's got PMDD, and I was trying to understand how things were at home, and she said that her husband just cannot get it. He's fine. He lets her just go off into a room and be on her own, and he recognizes the symptoms, but he simply doesn't understand. He can't get his head around why it's happening to her. So I, sometimes, and actually on reflection, I wondered afterwards whether it'd be good for me to see them as a couple, or at least offer that, to start to explain some of the increased understanding we've got about how women are different in terms of their responses to the changes in the hormones in their cycle and things. And so just remembering what might be going on at home is really important.
Yeah, absolutely. And I think it can be really isolating for women themselves as well, can't it? That if they're having this experience and they don't know anybody else who is, it again, that can be really difficult too. And the NAPS website has a section about personal stories, and I will often share that with people just to say, well, just have a read, and just to kind of help them understand that they're not the only one going through this, that it is very common and many people will have the same experience. So, yeah.
It's really interesting listening to people talking about their experiences and how that switch in their brain, and it just different women have got different ways of trying to explain it, but if you sit and listen to it, it's always like something has just switched in their brain. Something just feels like they're not themselves anymore at that moment in time. And yeah, if you get people in the room, patients in the room, spend a bit of time listening and exploring what it feels like, because it's really interesting. It's not like a simple mood disorder, is it? It's very, very specific.
Yeah, absolutely. Yeah, people often use the word switch, don't they, when they're going into those symptoms or coming out of them, like it just they'll click their fingers or they'll talk about something just changing. Yeah. So I'm going to move on to looking at management. So if we've made that, so I think making a diagnosis is really important as a first step. Validating somebody's experience, listening, especially if that diagnosis is quite delayed, just really allowing a bit of time if you can, which I know is difficult, just to kind of really acknowledge what they've been through, I think is very helpful. There's a link there to those personal stories that I was just mentioning. And then really, as ever, we're looking at kind of personalized management, really kind of taking into account what's important for the person in front of us. So thinking about what's happening for them, and particularly thinking about any fertility plans, because some of our management options will be contraceptive. So just kind of exploring a little bit kind of in terms of what's important to them, to know then where to go next. And I've got a couple of slides from the NAPS guideline to kind of look at some general principles initially. So again, I think particularly with younger women, they're very interested in knowing what they can do in terms of lifestyle, with diet, with exercise. So this can be helpful in kind of terms of talking through, well, what is the evidence base around different supplements? So helpful just to kind of think about a bit of a lifestyle framework in terms of supporting nutrition and movement, stress management, and a number of different supplements here that have got small but some evidence. So if people are particularly interested in exploring that, that can be really useful. And then acknowledging first, there are no licensed treatment options for PMS, but we tend to think around then the next step in management being looking at a psychological approach or a cycle suppression approach. So the psychological approach involves thinking about SSRIs and or CBT, and the cycle suppression approach essentially looking at contraception options or looking at HRT. So with the SSRIs, interestingly, you can use them in different ways. They can be used continually, or they can be used just in the luteal phase. So from kind of day 15 to about day 28. And that can be quite popular with women, I think, particularly because it's really showing them that you don't think they're depressed. You think this is a hormonal condition, and you're working with that kind of cyclical nature of their symptoms. People seem to get less side effects using them intermittently. And it's interesting because, of course, generally we think SSRIs take quite some time to kick in, but they seem to be really efficacious for PMS to be used just in this last 2 weeks of the cycle. And studies show that the intermittent or the continuous regimes seem to be about equally effective. So you can offer both and see what people prefer. There's no specific CBT available locally for PMS. It would be the general CBT that we'd be advising. And again, a trial that was done looking at CBT versus fluoxetine versus a combination showed that the fluoxetine worked the fastest. CBT seemed to have a better longer term effect, and there didn't seem to be an additional benefit from combining the treatments. So all three groups did show an improvement. So again, something, we can be sharing these different options with people and, using their preferences to think about which way we go. And in terms of cycle suppression, well, of course, if the person in front of you also needs contraception, this can be a great option. So the combined pill would tend to go with one of the kind of newer third, fourth generation pills rather than a more androgenic pill like microgynon, and think about perhaps using an extended use or continuous use of the pill, using a reduced pill-free interval. And again, it's been shown that SSRIs and the combined pills seem to have a fairly similar efficacy, so there doesn't seem to be much of a difference. So we can be, offering different things. If your patient's perimenopausal, you may be talking, and there may be additional benefits to thinking about using HRT. You don't get cycle suppression with HRT at standard doses, but you can sometimes with higher doses. So you do tend to need to go up to the 100 microgram patch, the 4 doses of estrogel, the 6 sprays of Lenzetto. And I've just put a little reminder on the slide there that since this guideline was written, we now know it's important to match that higher dose of estrogen with a higher dose of progestogen. So again, a number of different options depending on the preferences really of the person in front of you. And I think super important for us to remember to bring people back. Again, particularly if somebody's had a later diagnosis, has felt quite dismissed along the way with different interactions. If we encourage them to try something, really great to then try and bring them back after a couple of months to see if it's made a difference, because we have got a number of different things we can try. So just really supporting people that this is our plan A, but if it's not working well for you, let me know, we can go to plan B. So yeah, great to be thinking about some proactive follow-up. And of course, sometimes we might explore all of these different options with people. And if they're not effective, we can then think about onward referral for other treatments. In some areas of the country, there's an MDT approach and joint clinics between gynae and mental health. Don't have that in BNSSG currently. So, on some occasions, it may be appropriate to be referring to both specialties, referring to gynae for that specialist management in terms of the hormones, but potentially also referring to mental health for specialist support too. This is the summary from the RCOG guideline, which again starts with what we've looked at really already in terms of the lifestyle advice, thinking about the SSRIs or the cycle suppression, looking then at potentially adjusting that and using HRT and or higher doses of the SSRIs. And then if we're still not winning, consideration of referral for GnRH analogues with ADVAC HRT. And on occasion, hysterectomy and BSO with, again, then ADVAC HRT, especially if that's done at a younger age. So again, remembering that there are other options outside of what we'd be comfortable doing in primary care that we can potentially be referring people for. Anything you'd like to add to that, Harriet?
No, just had one question from Laura, who's just asked if a patient has moderate or severe PMS but is already on a continuous SSRI, would you increase the dose or consider increasing the dose in the luteal phase? I think you could do either of those. You could discuss both options to the woman, but there would be a good likelihood that if she just increased it in the luteal phase, it may well be helpful for her. I guess I'd want to know why she started the SSRI in the first place, and if it was for an underlying mood disorder or if it was for PMS, and whether it had helped her PMS symptoms when she'd started it, because if it had, then it would be worth trying an increased dose. And if she hadn't noticed any improvement in her symptoms with initiating the SSRI, then you might want to talk about other options like cycle suppression, as we've discussed. But yes, I think it's important also just to say it's an individualized approach, and every woman is so different, and sharing options with women is really important. And they will often have strong preferences about whether they want to approach it from the hormone point of view, or they want to leave their hormones well alone, or they want and the other way as well. They don't want to mess around with SSRIs and brain chemicals, and would rather go the hormone approach. So I think it is really useful to highlight to women that that those the interactions between estrogen and serotonin receptors and GABA in the brain, and that all options are managing managing that. So yeah.
Yeah, great.
And sorry to interrupt, Sam, but the other thing to take note of is the history. So if women have been on hormonal contraception in the past, that's a really good indication as to whether, you can ask them if they've been on it in the past, if they felt better during that period of time or worse. Some women will have been on, lots of women will have been on combined hormonal contraception or the progesterone-only pill, and be able to tell you what their experience of that was like.
Yeah, I think that's a really good point. Yeah, that's right. Just remembering to ask, and if they haven't got on so well, which pill was it? Was it one of the more kind of androgenic ones? In which case, you've still potentially got options. But yeah, that's really useful for personalizing. Great, thank you. So as I say, we'll share some of these. There's quite a few really useful kind of guidelines around. Got links here to a webinar that's been run by NAPS, where there was somebody with a lived experience who contributed, and quite a good podcast that was released recently by the Primary Care Women's Health Foundation, talking to Prof. Panay, who wrote the NAPS guideline. So a few kind of quite useful things there if you're interested in exploring this a little bit further. And then for patients too, there's some quite good resources in terms of just, explaining what's happening. And I really like things like the guide for talking with your kids about it, explaining to your 8-year-old that mum's struggling for this time, and also explaining things to work. Depending on people's job, their employment, it can be really, really, really difficult in the workplace. So again, some useful resources that people may want to share with their employer, with their families, to just help those conversations. So I'm going to come back to those cases in just a moment, but just want to really kind of encourage you just to take a minute just to reflect on whether there's anything you want to do next in terms of any further kind of learning or reflection around this. As I say, if this is something that you haven't come across so much to date, think about having a watch of the video or having a read of some of the stories just to kind of really understand a little bit more about the impact. Perhaps have a look in your practice, have a look, see how many people have been coded with PMS and PMDD. That might give you a useful indicator as to whether people are looking for it, whether they're asking the question. You could think about, sharing different kind of support options with patients if they have had a diagnosis. So I think always useful with these sorts of learning just to think, right, where's this going to take me? What's going to happen next? So just take a moment to think around that. And then we'll come back to our cases. So this was our lady who was 43, who'd had a long history of cyclical mood changes. The pill worked brilliantly, but then she had a PE. Extremely frustrating because for the first time in years, she had felt well. That cycle suppression approach had worked a treat for her. But now, of course, she's had to stop her combined pill. She's getting some hot flushes, some potential, but no other obvious symptoms of perimenopause. So what are we going to do? Do people want to perhaps post a few thoughts in the chat about what you may be thinking of?
Any investigations you'd think about? Anything else you'd want to know about what's going on for her at the moment? Any thoughts? It's very quiet, Sam.
That's all right. It's lunchtime. You're allowed to be quiet. We've done lots of thinking all morning. Harriet, I know do you want to talk about what you did, what your approach was?
Terry mentions check her FSH, and yes, I did. She was actually booked into I run a complex menopause clinic, and I think one of my colleagues had thought maybe she was perimenopausal, and that was what was sort of what the agenda was in the consultation. There was no family history of early menopause, and her periods were still really regular, and this history went back sort of 10 plus years, and had a massive impact on her for a really long time, to the point where she sort of was unable to work, as Sam has really well talked about, for a week of her cycle, I think it was. So she was actually, it was a really challenging consultation because she had her own agenda. She was a little bit aggressive. And I think just because she was so despondent about things going back to where she'd been. I did send her away for some blood tests. I did want to know what her FSH was. It was normal, although, as I'm sure you all know, that doesn't exclude an early menopause. But on close questioning, the hot flushes have been going on for, also 10 years, and were very cyclical. So I didn't think it was a sign. I didn't think it was clinically that. She had never had any VTE in the past. There's no family history of it. And she was on a DOAC. So yeah, what could I have, what did I offer her at this stage? Any thoughts what you would suggest? Of note, she'd had SSRIs over the years, and they'd been moderately effective. In fact, I think she's still on one. And yes, I did. I have, rather than, so Terry has suggested transdermal estrogen with Futuregestan. I've actually offered her, she needs contraception as well, so the IUS with add-back transdermal estrogen. And she's coming in a couple of weeks for her coil. She came in last week. She came in last week for her coil fit, and had sex 3 days prior unprotected. So although I'd very clearly sent her a message that she should avoid that, so she was a little bit cross about that again, but I've squeezed her into another clinic to get her Mirena fitted, hopefully, and get her onto some transdermal estrogen, which is safe, with a history of PE, especially while she's on her DOAC. Of note, I think, Sam, I would start at a high dose in these women who are younger. I wouldn't sort of, unlike in the perimenopause, or when you're treating symptoms of the menopause, I wouldn't stepwise increase the dose. Would you? I would just start at a dose that's likely to suppress ovulation, which would be 100 microgram patch.
Yeah. I sometimes talk with people around either starting at that or starting a bit lower, but with the expectation will go up quite quickly, particularly if they're a bit wary about using hormones and not so keen on going straight in at a high dose. But
and if any history of migraine or anything that might be exacerbated by a high dose, by whacking up the estrogen in your system, be careful in those situations.
Yeah, exactly. Yeah. Super. Well done. Poor lady, it must be so frustrating, wasn't it?
Yeah.
It helps, and then just to be taken off it must be maddening, really difficult. And then this was our second case, so 44-year-old lady with the background of generalized anxiety, but with particular symptoms, again, in the luteal phase. So anxiety in the luteal phase, and also dissociative symptoms. Again, with a real theme of kind of not really feeling that that's been acknowledged or sort of listened to over the years in terms of that cyclical nature. So again, team, any ideas about what we would think of, what approach we might take?
This would just add a bit more to the sort of to how the consultation sort of was. She has a really very anxious personality, and I think that's probably meant that previous clinicians have found it quite difficult to unpick the cyclical nature of some of her symptoms and have put it down to just her anxiety. So yeah, it was yeah, it was also a challenging consultation. She came with her husband, but these symptoms have been going on for 10 years. I think she'd been investigated by neurology for possible epilepsy, and it'd been written off. She'd been told she didn't have it, and then she'd gone in again with these slightly odd, sounds like sort of, it could be interpreted as absence attacks, rather than any evidence of any sort of tonic-clonic seizure activity or anything like that. Never post-ictal, no other sort of epilepsy type symptoms, no family history of that, no past history of that. So she was in a right pickle, having been told that that's the diagnosis, and needed to start anti-epileptics when she didn't feel that that was what was going on. I'm obviously completely unable to interpret EEGs, and she had one, and that was what the neurologist was going on. But it was one of those consultations where, yeah, listening to the story, listening to the person's experience, and that sort of experience of people not listening to her concerns over a decade, and the impact. She came in with her husband, who eloquently described how cyclical things were, and yeah, quite soul destroying for her over the years.
Absolutely.
She was on an SSRI for her generalized anxiety disorder. So yeah, I mean, we talked about all the options. I think for her, actually, she'd been on the desogestrel progesterone pill for a really long time, and identified to me that she felt loads better when she was on it. And I guess that was through ovulation suppression, and indicating that she wasn't sensitive to progesterone hormones, and not all women are, even to the synthetic ones. And we quite often hear women telling us how they can find certainly micronized progesterone, the body identical progesterones, quite calming and sedative. And so it's just important to sort of look at the big picture, know what hormonal sort of, the history of hormonal contraception and how women had felt on that, share a management plan, including SSRIs, considering other things like she had a high BMI, so I couldn't offer her the combined pill. And the other thing that I did was write to neurology to explain that these symptoms was the cyclical nature of her symptoms, and that she was concerned that it was hormonally driven. And so I didn't do anything sort of big like fit a coil for her at the time, or add some estrogen, but have a plan to review her again once she's seen neurology again, and had that follow-up appointment.
Yeah,
and started on desogestrel because she felt well on it previously. So yeah.
Yeah, great. And yeah, absolutely, because it can give that psychosuppression, can't it? And something like Slin now as well as another option with these newer POPs that we've got coming through. So traditionally, we've always thought of progestogens as being the bad guy in terms of mood disturbance, but actually, again, everybody's different. And if we can get that psychosuppression or use the drospirenone progestogen, that could be a really good option. So yeah, that's really helpful. Thank you. Super.
I think the other important thing is, as I think you've highlighted it, Sam, but just making sure that women can come back, and arranging follow-up, because these women, I think, as the cases identify, have often been suffering for a really long time, and it's often the first time that they've so there's quite a lot to cover.
Yes.
And if you can offer them that support and that sort of continuity, I think it does make a massive difference to them.
Yeah, that's right. The relief of just being seen and heard is huge, I think, isn't it? Just to have somebody who understands is really, really valuable.
I think that second case, I think her words were, because I always try and establish ice right at the beginning, and I think I asked her, what is it that you're expecting from this consultation? And I think her words were just to be listened to. So that gave me a good
Yes.
heads up
Great.
of what I needed to do. So I did that.
Well done, brilliant. Well, thanks everybody for coming along today. Please do